Apnea testing, what respiratory therapists need to know. Essential insights for effective patient respiratory assessment. Hey friends, welcome back to Breathe Easy, the podcast where we break down high-stakes respiratory care into clear, practical bedside knowledge. Today we're talking about apnea testing, one of the most critical and high-risk components in determining brain death or death by neurological criteria, also known as BD/DNC. I'm your host, Danielle Hardy, Clinical Respiratory Specialist of Adult Services at ECU Health. Again, this episode of the podcast emphasizes the importance of apnea testing as a direct assessment of brainstem function. This aligns with the policy ECU Health Policy Apnea Testing that was updated last September 2025 and went live this past fall 2025. This reflects the latest Pediatric and Adult Consensus Guidelines on brain death testing published by the American Association of Neurology in line with the Society of Critical Care Medicine in fall 2023. Our prior policy was from the guidelines that were established in 2010. This introduction sets tone for understanding why apnea test matters, who should be involved, and how to perform it safely and effectively. This episode aims to empower respiratory therapists with confidence and clarity when managing this high-stakes procedure, ensuring patient safety and adherence to best practices. Significance and risk. Apnea testing is not a routine checkbox. It is a critical evaluation of brainstem function. The test determines whether the respiratory centers of the brainstem respond to a controlled hypercarbic and acidotic stimulus. If carbon dioxide levels rise and the patient makes no respiratory effort, this indicates the absence of brainstem activity. However, the procedure carries significant risk, including hypoxemia, hypotension, and arrhythmias, which require meticulous planning and teamwork. Understanding these risks underscores why apnea testing demands precision and adherence to protocol. It is a cornerstone in confirming brain death and death by neurological criteria testing and ensures that decisions regarding end-of-life care are based on accurate evidence-based assessments. Policy requirements and team composition. Before initiating apnea testing, a formal order from a licensed provider is mandatory. According to policy, adults require at least one apnea test after the final neurological exam, while pediatric patients need 2 tests. Pediatrics also has their own policy, one after each neurological exam. If the attending physician is not physically present, the bedside team must include a physician, a respiratory care practitioner, and a nursing representative. Continuous cardiac monitoring and pulse oximetry are essential, and the covering attending must be informed before procedure begins. These requirements ensure that the test is conducted under optimal conditions with appropriate oversight, minimizing risk and maintaining compliance with institutional and national guidelines. Patient stability and safety checks. Apnea tests should only proceed when all the brain death or death by neurological criteria prerequisites are met. I will share with you at ECU Health there is a brain death navigator that the physicians use to document all the prerequisites prior to ordering the apnea testing. Hopefully, if it was documented correctly, all of these items should be in the correct targets in order for us to proceed with the test. If you have a question about a prerequisite, come across collaboratively as a team member. And definitely speak up if you have a question. We want to make sure that we're doing the right thing for the patient, because if any contraindication exists, the test cannot proceed, and as doing so compromises patient safety and test validity. Managing carbon dioxide levels. Proper carbon dioxide management is critical for accurate apnea testing. There are 3 scenarios. Patients without chronic carbon dioxide retention should have a PaCO2 normalized between 35 and 45 millimeters of mercury and a pH between 7.35 to 7.45. For those with known chronic CO2 retention, ventilation should match their baseline PaCO2 and pH. If chronic retention is suspected but baseline is unknown, an estimate is made, but ancillary testing will be required if no respiratory efforts occur. Mismanagement of carbon dioxide baselines can lead to incorrect interpretations, making this step one of the most error-prone aspects of apnea testing. Understanding these distinctions ensures accurate and reliable results. This was an update from the 2010 guideline previously to now the new 2023 guideline that have been published. Preparation for safe testing. Before disconnecting the ventilator, pre-oxygenate the patient for at least 10 minutes on a FiO2 of 100%, targeting a PaO2 greater than 200 millimeters of mercury. Obtain a baseline ABG then, and ensure all necessary supplies are available, including equipment for multiple ABGs, vasopressors, fluids, and inotropes. Staff must be prepared to manage cardiopulmonary instability, as apnea testing is a controlled physiological stress test. Proper preparation minimizes complication and ensures that the procedure can be completed safely and effectively. Best techniques for oxygen delivery according to the 2023 guideline. There are two primary methods used for apneic oxygenation during testing: tracheal insufflation and CPAP. Tracheal insufflation is suitable for adults over 18 years old and involves placing a catheter just above the corona with a diameter less than 70% of the airway and delivering 100% FiO2 at 4 to 6 liters a minute. CPAP can be used for all patients and should maintain a FiO2 of 100% in the same PEEP as before testing. Acceptable CPAP setups include a float inflating bag with a PEEP valve and a T-piece with a PEEP valve, or a ventilator in CPAP mode with backup apnea ventilation disabled. Proper techniques prevent auto-triggering, which could falsely indicate respiratory effort and invalidate the test. Observation and the new sampling protocols. During apnea testing, observe the bare chest and abdomen for any respiratory effort and palpate if necessary. Continuous monitoring of electrocardiogram, arterial pressure, and SpO2 is essential. If CPAP is used, monitor flow waveforms. PaCO2 typically rises 2 to 3 millimeters of mercury per minute, so ABG sampling should begin around 8 minutes and repeat every 2 to 3 minutes if the patient remains stable. The test usually lasts 10 to 15 minutes but may continue longer if stability is maintained. Accurate monitoring ensures timely intervention and reliable test results. Please note that these ABGs can be performed with an ISTAT or EPOC as well. They just need to be recorded in the chart. Here for positive tests and safety stops. The apnea test confirms brain death or death by neurological criteria if no respiratory effort occurs and the ABG shows a pH below 7.30, PCO2 above 60 millimeters of mercury, and at least 20 millimeters of mercury above the baseline. If chronic CO2 retention is suspected and baseline is unknown, ancillary testing is required. The test must be terminated immediately if spontaneous respirations occur, systolic blood pressure or mean arterial pressure drops below thresholds, SpO2 falls below 85%, or significant arrhythmias develop, or bradycardia below 60 beats a minute occur in infants. These criteria protect patient safety and ensure the integrity of the testing process. Recording and post-test care. Documentation should include a procedure timeout, duration of apnea, ABG results, observations, adverse events, and all staff present. After reconnecting to the ventilator, increase minute ventilation temporarily to restore normal oxygen and normal ventilation. Proper documentation ensures accountability and compliance with our current policy. This is new. So closing remarks emphasize that apnea testing is one of the most technically demanding procedures for respiratory therapists, requiring precision and teamwork to safeguard patients and uphold the integrity of brain death and death by neurological criteria determination. I wanted to do this episode specifically on this policy just because some questions have recently been raised. Also, I had sent out information and I understand that there might be some questions regarding the changes. There have been some changes within the past 13 years, and luckily we have organizations that come together to provide us these updates, but I wanted to be able to take the time and share how it affects us, the respiratory therapists at the bedside. Thank you, and see you next week for the next podcast episode.